then let's give him a hand and
Get a hand before we start.
Yeah, you do.
Okay, well, so I'm Lisa Colbert. I'm a professor in the Department of Kinesiology. And to tell you how I got where I am now, I'll start based on some of your questions by telling you I never grew up wanting to be a professor or ever all through undergraduate career thought I would be a professor. But that's where I am. So the way I got here was I was always interested in athletics as a kid, and I ran competitively in high school, and I thought for sure I wanted to be a physical therapist. And so back when I was in school, that was an undergraduate degree. And kind of like kinesiology is here, it was competitive such that you applied in your sophomore year for entry as a junior. And so halfway through my sophomore year, my advisor told me, you're never going to get in, your grades aren't good enough. Find another major. So, and that was all, I had thought I was going to do. So he kind of suggested athletic training, which is I'm sure you've heard a little bit about. So it's pretty similar to physical therapy in many ways. And that you could get into, that was a program that I could just transfer right into. So that's what I did. And I enjoyed athletic training, but meanwhile I also ran competitively in college. And so unlike many of the other athletic training students, I didn't spend as much time with teams actually out on the field and dealing with emergency situations. I was the person in there before my own practice taping ankles and doing a little bit of the rehab, which is what I was interested in. And when it came time, I graduated. I went to the University of Delaware, just because go Blue Hens. Yeah, a lot of birds. And so when I finished, I tried to get a job as an athletic trainer, and I couldn't actually find a job. I started looking my senior year. And one of my professors said, I really think that you ought to apply for grad school here. And again, I never thought about going on for graduate studies. So I thought, well, I'll apply. Nothing else is not working out right now to get a job. So I applied, and I got in, and so to stay at the University of Delaware. And there were only two program areas there. It was either biomechanics or exercise physiology, and I got to pick. And so because again I was a runner, and I thought the only thing I knew about biomechanics was that you could maybe design running shoes. I thought, oh, that sounds fun. I'd like to design running shoes. So I picked biomechanics. And then about 2 weeks before the fall semester started, I got a phone call that said, if you want to TA or be a teaching assistant in exercise physiology and do exercise physiology, we'll give you a stipend and pay your tuition. So I said, all right, I switch. So I decided to do exercise physiology. So I really enjoyed it, liked it a lot. But again, never ever thought I was going to go on and do my PhD. But finished up, and I was working in during my master's program, actually, one of my other students in a class I was in gave a presentation. She had researched studies on exercise and cancer. And I thought that was really interesting. And actually, in high school, my mom had died of cancer, so I was really interested in that. And then, but it sort of was just in the back of my mind. But then after graduating, I was working in a fitness center, and after sort of doing the same type of things every day, I realized that I didn't think that was really going to be for me. So I'm not really an extrovert, so probably different from Jean, dealing with different people every day. That's not really my MO. And so I thought, I think I do want to go on and do research, because I'm really interested in this exercise and cancer thing. So I did apply for a doctoral program at the University of South Carolina, and that's what I did in exercise physiology, and I studied exercise and immune function in mice. And then once you get to that point, you're pretty much, if you're going for your PhD, you're probably going to be a professor. So, so as I was doing that, I really liked it. I liked the physiology, but I always sort of wondered if what I was doing in mice, how that really applied to people. And so I learned about this field called epidemiology while I was doing my PhD, which is the study of disease and its determinants in populations of people. So I was really interested in that. And nowadays in science, if you want to be a professor at a big research-based institution like UW, you really do need to go on beyond your PhD to something called a postdoctoral fellowship, where you get more research experience. So I did one at the National Institutes of Health, where part of that was to get another degree. I got my master's in public health, where I learned about epidemiology and how to study. I studied physical activity and disease in populations. So I did that. It took me one more year to get my MPH, and I did 4 years of research at the National Institutes of Health before coming here for my job now. And so I think one thing I've found is interesting when we talk to our kinesiology students is that I think many of them don't actually know what their professors really do, because you see us as teachers and maybe think that's all we do. But that's really about 50% of our job is teaching. The other half here at the University of Wisconsin is research. And so I study largely exercise and cancer. And I used to do more studies that Cindy mentioned in terms of exercise and the prevention of cancer. So if you're more physically active, are you less likely to develop breast cancer, for example, which you are. But since coming here and those types of studies are studies of thousands and thousands of people, because cancer is so rare. So you need to do these large studies where you have enough people get that sort of endpoint to see if being more active is related. So since coming here, I've sort of shifted to a different study type just because it's more easy, really, which is to look in people already diagnosed with cancer, what are the benefits of physical activity to them? So for most people getting cancer, aging is the #1 risk factor for any cancer. And so we look at things like, if you're more active once you've been diagnosed, do you function better, physically function better? Or is your quality of life better? And then ultimately, we're interested in, do you survive longer after having been diagnosed? So I kind of work at a few different ends of the spectrum. My niche is subject area, which is physical activity and cancer, but I look in populations, and then I still do some mouse studies, because ironically, the mouse I used at the University of South Carolina as a grad student was actually developed here on campus. And so I now work with some of the people who developed that mouse that gets, it's a model of colon cancer. And so I still do a little bit of mouse work. So about half it's on paper, half of the time is teaching, half the time is research, but then we do a lot of sort of service type activities as well. So that's kind of how I got where I am and what I'm doing. Jean, you want to take over?
Please keep in mind that Dr. Colbert started when she was 10. Lots and lots of years of study. I'm Jean Einerson, and I'm a clinical exercise physiologist. And when I was a freshman in college, I had no idea that I would end up doing what I do or did for 26 years. Briefly, I was very interested in biology and physiology in high school, and I had a wonderful teacher, a biology teacher who was a great mentor to me. And when I went to do undergrad work here in Wisconsin, not at this university, at another university, I also loved physical activity. So I had a double major in biology and physical education with a teaching certificate. Loved undergrad. One of the I competed in college as well, so exercise has been a part of my life. Not so much competition, but certainly exercise. One of the last courses that I had to take for my degree was exercise physiology. And back then, that was even before Dr. Colbert's time, this was relatively new. It was a pretty new field, and the professor that taught it was very good, very excited about exercise phys, and had a passion. And I always kind of kept that in the back of my mind. But I did graduate, and I went on to teach in a high school here in Wisconsin for 5 years, and had fun doing both physical education, and I taught biology and physiology in the classroom. So it was kind of a perfect mix for me. However, after 5 years, this kind of dinging in the back of my head came to a forefront, and I guess I wanted something different, another challenge. So I applied here to the University of Wisconsin, and at that time they had a very strong human exercise, a physiology program. It was nationally known, and fortunately I got in. Not that my GRDs were that great, but I got in, and I got a teaching assistant. I was a TA, which helped. So here I am, a master's in exercise physiology, just finding out what I could do with it. And at that time, you could do three things, basically. One was to go into corporate fitness. That was a hot thing 25, 30 years ago. It's hot again now. Employee fitness programs are very, very hot because they want to keep costs down on their employees as far as healthcare costs. So you could do that, or you could go into research, and that would be what Dr. Colbert did. And thirdly was more the clinical route, working with patients, specifically heart patients, or pulmonary patients, those with diabetes. And I had kind of a wise professor who kind of steered me into the clinical route. And I'm just so thankful for that. And if there's any message I can give to you before you leave today is work with your advisors and find mentors. Really do that. Someone that you can talk to, that you trust. But boy, he knew me, and he steered me in the right direction. So I ended up working in cardiac rehab during my master's program. And at that time, we had to do a thesis, so a research project. And it just so happened that when I graduated, the person that was working in the clinical program got married, left town, and I took her place. So then for the last, I'm semi-retired now, but for 26 years, I directed the cardiac rehab and preventive cardiology program here at University Hospital. So my journey's a little bit different. So there's just know that there's different tracks and roads that you can take. You may have to veer off a little bit, but keep asking the questions. Be reflective, if anything. Please be reflective. The kinesiology program here is outstanding. It is just great. You've got the best professors. It's going to prepare you to do many, many different things, which is wonderful. You're lucky. I hope you know how lucky you are. But when you're choosing, don't be too quick to decide, yep, I'm going to do PT and that's it, or I'm going to do AT and that's it. Please be open to look at other things. That's my journey. What's next?
Thanks. Now, if you can just, both of you expand too on what you're doing currently, brag about yourselves a little bit.
Sure. So, and some of the questions are sort of like, what is your day-to-day day like? So, so like I said, I sort of split time between teaching and research, and you know what teaching's like because you sit in the other side of the class every day. The research I do is, like I said, largely related to physical activity and cancer. And so the epidemiologic studies have been, I don't work one-on-one with people like at all, really, in the work that I do. Although some of the studies I've done more recently do. But so when I study physical activity in cancer survivors, for example, so we wanted to know if people were diagnosed with colorectal cancer, for example, how well do they function, and is that function related to their physical activity or how much pain they have? And so we did that, an epidemiologic study of just under 1,000 cancer survivors in the state of Wisconsin via survey. Because if you think about, if you wanted to know, does exercise improve function in cancer survivors, and you needed about 1,000 people to do that, just try and imagine the logistics of putting 1,000 people through an exercise training program for long enough to know, does it affect their physical function? It's difficult. So that's what epidemiology does, is it sort of lets you work with endpoints that you might not otherwise practically or logistically be able to do in terms of a regular experiment, as you guys think of experiments. So in exercise, if we think of an experiment just like others, it would be sort of putting some people do exercise and some people not and seeing what happens. If your endpoint is cancer or cardiovascular disease, you can't do that. It's logistically not possible. So a lot of the work we do is with surveys and such, and so we can just sort of correlate and initially look at things like the people who, which is what we found, the people who reported more physical activity had better physical function. And actually what it looked like, it was that just doing something really improved function more, or function was better in those people. One of the problems with our field is that we often use surveys to do our measurement. And so if you think about how much physical activity you do, if I was to ask you to tell me over the past week how much physical activity you did, if I just asked you like that, I mean, I would get 117 different answers, right? So we come up with surveys, but even surveys are difficult to answer. So you could probably tell me pretty well how much vigorous activity you've done last week if you do that, or if you don't. That's easy to remember. But if I asked you how much you walked last week, would you be able to tell me an answer to that very well? Probably not. It's really hard to sort of quantify. So a lot of what I've done more recently is try and figure out better ways to measure the physical activity that people do. And so we've done some studies where I actually did get to see people in my laboratory where we would put new gadgets we have. Some are less new, but you all know pedometers. They're actually ancient. But then we have accelerometers that measure acceleration. Or there's more fancy ones. If you guys have watched, I don't know if they use them anymore, but The Biggest Loser, they used to wear those armbands. That have multi-sensors to measure activity. We've tested those as well. So we've kind of been testing different ways to measure activity, and are realizing that people really don't do a good job of self-reporting how much activity they've done. So now we're hopefully going to take some of those measurement tools and move them into studies again where we better quantify what people do and look at endpoints. And so most of it will be in cancer survivors and older adults. The mouse work that we're doing is, I actually mostly study colorectal cancer because it's pretty prevalent. It's the third most common diagnosis in both men and women. And there's pretty good survival rate. It's about 50% at 5 years, which admittedly is not good, but compared to lots of cancers is okay. And so I'm studying that in mice as well. So like I mentioned, there's mice on campus that were genetically modified such that they get tumors in their intestine. And so we give them running wheels and look to see if we just let them exercise, or if we exercise them and sort of restrict how much food they eat so that their body weight stays low, what happens to the tumors. And we do that in mice because in people, if we see activity sort of prevents colon cancer, but we don't know how, people don't really like you taking out chunks of their tissue to see what's happening. But in the mice, we can take out intestine and muscle and see what's happening. So those are sort of the things we're doing now. We're also branching out into some lung cancer patients. And so we're putting some of our monitors on these patients to see, first of all, something I learned in the last few years was that oncologists, when they see and diagnose a new patient with cancer, not everybody gets chemotherapy with the usual line of treatment following surgery. And it sort of depends on how they function. There's something called performance status. And so if a person is not functioning well enough, the chemotherapy can actually be harmful. It can be so overwhelming that they will actually die sooner. But their cutoff for who gets chemo and who doesn't is, are you up and about more than 50% of your day? And again, it's sort of the clinician's impression of the person and what that patient tells them as to making that decision. So when I had shown people in the cancer center my little instrument that gets worn on your thigh and actually quantifies how much time people spend upright, they were all excited about it. So we're putting them on these patients to see how my gadget compares to what the patient says to what the clinician thinks. And then hopefully also seeing how much they're up and about relates to how long they live following their diagnosis. So that's kind of what my research is. And so day to day, it really varies. Like today I haven't done, did I do any research things? Today was an all service day so far, where I'm evaluating a program that's in our department. And so I was preparing reports and meeting with our department chair about that. It had nothing to do with science or teaching. And then tomorrow's a fun day, but a totally different kind of day, where we have a guest speaker coming to campus to give a talk in our department about walking in older adults. And I'm his host. I invited him. So he'll come in the morning and we'll meet with him and a couple other researchers on campus to talk about how we might collaborate. He's from the University of Wisconsin in Milwaukee. And then we have meetings in the afternoon, departmental meetings. So the one thing I love about my job is that every day is different. There's lots of variety to what we do, and the research is awesome because you pick what you want to do. That's the best thing about it. You decide what's of interest. It's not like you guys go into chemistry lab where they tell you, do this experiment, tell me what you found. You get to say, this is the experiment I want to do, and assuming you can find money, somebody gives you money to do that if you need money, you get to look at whatever question you want. So that's a fun of the job. I saw some of the questions are there any parts you don't like about your job? There aren't many. I love my job, but one of the few things, sometimes I'm jealous of my friends who might have jobs who, when they go home at the end of the day, they don't think about their work at all. They're done and can enjoy their families. And always, you're always thinking about the paper you should be writing or the next lecture. There's always something that is going on. So sometimes it's hard to sort of turn that off, but the trade-off is that you get to do so many cool, different things. So I wouldn't give up my job. I like it.
I thought before I share what I would do in a day, I'm not sure if all of you know what a clinical exercise physiologist is. So if I could share like 2 minutes to define what a clinical exercise physiology is and what we do. A CEP is defined by the American College of Sports Medicine as a healthcare professional who's trained to work with patients with chronic diseases where exercise training has been shown to be of therapeutic or functional benefit, but not limited to cardiovascular disease. And there you have 3 different types of cardiovascular disease. I worked with all 3. Pulmonary disease, COPD, is chronic obstructive pulmonary disease, emphysema, asthma. I worked with these patients. Metabolic disorders, diabetes and obesity, of which, as you all know, are on the rise in the United States. And I think one of the questions was, how does your work tie in with kinesiology and the work with physical activity? Well, I think it is a perfect marriage and match. Here is just looking at percentages of people over the age of 65 who reported having selected chronic conditions by sex. Men green, women orange, and as you can see here, heart disease, hypertension. It's almost half in hypertension, stroke 10%. So it's there. The work never dies. It's there. It's always going to be there. And here's this is death, mortality by sex. Looking at A is total cardiovascular disease. This is per year in 2004. Cancer, accidents, chronic. D is the COPD. So again, the prevalence is very high. Have you heard of the Healthy People Initiatives? Here's 2010. Physical activity was number 1. Overweight and obesity 2. Tobacco use 3. Every single day I work with that. I counsel people on how to stop smoking, which is maybe one of the hardest things that I do. But physical activity, certainly monitoring a patient that had bypass surgery, that had a heart transplant, making sure they're safe, and then getting them back to be functional. And now the new objectives for 2020 has come out. They've kind of changed it this year compared to 2000. They kind of have overarching goals now. One goal is to increase quality of life and years of healthy life. And I think you heard Dr. Colbert speak to that in her cancer research. That's a very important endpoint. And eliminate health disparities. You're disabled, it's going to cost more. A lot of it comes down to money, unfortunately. And then they divided it down into 28 different focus areas. 3 of them are physical activity and fitness, heart disease and stroke, and respiratory diseases, of which a exercise physiologist works with every day. So what makes a career match? What kind of characteristics, skills, things that you like, who you are, your personality might match with being a clinical exercise physiologist? As any healthcare, if you go into athletic training, physical therapy, occupational therapy, you gotta like people. You gotta like them, have fun, want to work with them. You also have to be a good listener. Probably half of my job is listening, listening to concerns, not only patient but family concerns. This is a pretty big deal. You may know of somebody in your family, grandma, grandpa, uncles, that have had a heart attack, bypass. It's a big deal. Or maybe someone that died suddenly. So you got to listen. And as I mentioned, you like working with people. I love working with people. I also love science. I like the science part of it. I love physiology. When I was 16, 17 years old, I still love it. So it's putting the exercise in with the physiology, the science part of it. I like to exercise. I still do. Sometimes it's harder. Some days are harder, but I still love it, and I like to encourage people to do it. I enjoy challenges. Working with people that have respiratory or vascular disease is not easy, and there's a lot of barriers. But I like that. I kind of see that as a challenge and enjoy that. And I like learning new things, even in my old age, including research. I try to keep up to date with what's happening. In order to do, I think, a good job, you do need to keep up with research. So I don't know if I guess we kind of went through education, but some of the things, some of the courses that I took, was in pharmacology, nutrition, exercise phys, of course, disease pathophysiology, exercise testing and training, a lot of ECG interpretation because you're monitoring these patients, so you need to understand how to read the ECG and what to do. Epidemiology, with what Dr. Colbert teaches, I had several classes in that. As far as the clinical practice, it's not soft. This is pretty hard science. We do evidenced. We take evidence-based research and use it, transfer it to clinical practice. And most of my work was done with adults. I have worked with pregnant ladies, part of my life, and doing prenatal exercise, worked with diabetics. But probably 75% of my work is with heart patients. I taught. I had the luxury of being here in an academic area where I would come in and teach to PT students, to OT, nursing. So that was a lot of fun. I enjoyed that, and did do some research, not on my own like Dr. Colbert does, but certainly and collaboratively with others. Some of the skills, I didn't have a clue when I started how to do an exercise test. Anyone here run on a treadmill, be monitored? Has anyone ever had a stress test? Yeah, you're too young. You don't need to. But how to conduct a test, know the safety of it, exercise prescription, which isn't just saying going out and do it 3 times a week or walk 150 minutes a week. It's really kind of an art form based on who you're working with. As I mentioned, ECG and to risk factor behavioral counseling, so it's the psychology of it. Health coaching, which is kind of a new term. And knowledge of medication, exercise, interaction. And that's what I really enjoyed about clinical exercise phys, is that you're applying it. You're taking your physiology that you learn in the classroom, and you are actually applying it when you're working with a patient. And and you kind of have some free reign with it. It's a little bit different than physical therapy or athletic training, where it's quite protocolized. You have a certain injury, and this is what you're going to do. With patients, heart patients especially, safety is very important, but you have a little bit more creativity to work, and depending on what that patient's needs and goals are and how functional they are. So I love that. I love kind of having that freedom. Some of the services that we work in the hospital or ambulatory setting is, I've done thousands of exercise tests, exercise prescriptions, supervision, health risk screening for prevention. I actually went into corporations and did screenings, counseling. Part of my research was looking at health-related outcomes. And I worked both in inpatient and outpatient settings. So I did spend time at the hospital, which is a whole nother gamut. Seeing someone laying in a bed compared to walking on a treadmill. And what's fun is it's a collaborative team. It's, I'm working with physicians, nutritionists, psychologists, nurses. It's very, very fun. The exercise physiologist does have a certification. Through the American College of Sports Medicine, you can take a test to become a clinical exercise specialist. It is a written test, and it's also a laboratory test. You have to do on-hands work as well. And as of the past 2 years, you can take another exam to become a registered exercise physiologist. And what that test does, it adds more neuromuscular populations to your work. So if I saw someone with an RCEP behind their name, I've known that they've taken that extra test. Why did I do this? Why do I do it? Because cardiovascular disease is the #1 cause of death in the United States today, and even though we're improving, we're coming down, it's still the leading cause. And I think it's important to be a part of trying to help people, especially for me, is not to have another event. I took much pride in watching a patient and their family change their lifestyles and to eat 3 meals a day and add a green vegetable. It may sound silly and stupid to you, but those little bit of changes can prevent another event, another hospitalization. And you do make a difference. If you like research, there's funding out there. There's lots of it. It's very rewarding. So when I was practicing, I would see heart patients in a class setting. I would see them one-on-one. I would do exercise testing. I was also an administrator for a while, so I did a lot of managing and budgets. You don't want to do that, let me tell you. You just really don't want to go there. Stay with the patient care. Now I work in a research lab, and something that this degree gives you is physicians, especially that run research labs, know the physiology that you know, and it's really helpful. So right now, I look at vascular function and through ultrasound and through tonometry or a pulse wave velocity. So it's a whole nother kind of life after my clinical life, and I'm very, very fortunate to have it. What do we got? 2 minutes? 5 minutes? Questions?
What requirements are there for those degrees get certification?
Excellent question. As a bachelor's degree in exercise science, excuse me, you can take a certification to be a fitness instructor. That's a good way to start. I think it costs like $300. To sit for the exercise specialist and RCEP, you do have to have a master's degree and 600 hours of a clinical internship that's supervised. Good question.
No others? You're not going to get off the hook because I have the whole list. We'll start picking them. No burning ones?
I got a question for Lisa.
Yeah.
In your research, did you notice any difference between, in looking at the advantage of exercising after having had cancer or while fighting cancer, any difference between those who had a history of exercising in their life and those who didn't? Or is that not a question?
Yeah, so the question is there a difference between people who with exercise being beneficial post-diagnosis? Did it matter if they exercised or not pre? So that's not something I've looked at in my own studies. Other people have, though, but again, it comes from survey data, usually where you're trying to recall what you did many, many years ago. But that said, it seems like it's never too late to be active, and that's, for example, being active in high school and then never being active again is probably not protective. It might confer a little benefit on certain things, but for most chronic disease outcomes, we don't know if it's because we measure what you're doing recently better or not, but it seems like what you do recently is important. So, I mean, I think that's important, and it's an important point because it suggests for any age, it's not too late to start to adapt these behaviors. Any others?
I got one for Jean. So you mentioned preventative, and most of those are treating patients who had some issues. So what do you do on the preventative side, and what patients come then? Are you just trying to prevent recurrence? But that's kind of rehab too.
Right. I think your question is primary prevention versus secondary prevention, and about 75% of my work was secondary. The person had the event, had a heart attack, bypass, what have you, a stent. So we're trying to reduce their risk for another event. 25% of my work, we had patients that were referred by their physicians that had cardiac risk factors such as high cholesterol, hypertension. They were smokers. So their physician felt that the work that we did would help them kind of adopt a lifestyle change to reduce their risk. Does it? Yeah, it does, but you need large numbers like she works with in order to prove it. It's a challenge. It's maybe you know of people in your life that could adopt a healthier lifestyle and just don't. So usually if you've had your chest cracked open, and that's kind of a rude awakening for people, so it's a little easier to work with. But other than that, that's a good question. I think you have to find each person's intrinsic motivator. It's different for everyone, you know. For many, it might be family. Hopefully, it's something that they've found that they need to do themselves. So every one of you, I hope, exercises, but you may do it for a different reason, or you don't eat hamburgers every day because whatever.
Looking at some of your questions, I think I'll take a minute to reiterate what Jean had said, which is that we know, because when some of you who will get into kinesiology program, I always survey my classes, and so what do you want to be? And probably 85% of the class says physical therapy. And I don't actually know how many go on to do that. But what Jean said, and hopefully both of our trajectories should show you that what you think you want to be right now, don't get too set on that, because things happen, and you guys are young. Like at 18, 19, it's hard to know what you want to be for the rest of your life. And I thought I knew kind of what physical therapy would be, and I liked exercise, but the reality of day on day following these prescription for this injury and having to put on my small talk face with people, it wasn't until I was older, like now I look back and think, oh my God, I'd be horrible physical therapist. But that's so what I thought I wanted to do, and by this series of accidents, I now do something totally different. So be open to that. Don't get frustrated if things aren't going as you think they ought to right now, because hopefully you all have a lot of life left.
And nothing's wrong with PT. I mean,
Yeah.
no, I mean, we aren't saying that, but
No.
just be reflective. And I can't just think of a better word, and find a couple mentors.
Yeah. Yeah, many of you will think that you should never go talk to your professors, or you're afraid to, and don't do that. Especially, you can think about it now, but if you do wind up wanting to go to PT school, and as seniors you ask your professor for a recommendation, and they've never heard you speak in class or come to an office hour, you're not going to get a good letter. So don't be afraid to seek mentors and meet your professors.